Infants born with a cleft palate and small jaw, called Robin sequence or syndrome, require special consideration. This is a rare cleft occurring in about 1 in 10,000 births. The diagnosis involves a series of physical findings: small or retrognathic jaw, glossoptosis tongue, which is a tongue that is placed towards the back of the throat, and a cleft palate. In addition to these findings, syndromic Robin babies can also present with additional findings, including Stickler Syndrome, associated with myopia or nearsightedness, muscle and joint issues, positive family history, and a positive genetic test. Robin diagnosis is graded on a 1-3 system. Grade 1 means the baby can eat and breathe with good positioning and feeding technique. Grade 2 means the baby can breathe fine with good positioning, either prone or on the side, but cannot eat without compromising their airway. And Grade 3 is when the baby can neither eat nor breathe without some sort of assistance.
If any of the triad of signs are present at birth, the infant should be positioned on his side or prone, monitored with a pulse oximeter. Do not attempt to feed the baby orally until the airway and oxygen level are established. If the baby is unable to eat, then place a nasogastric tube for feeding until the treatment plan is established or until the infant is transferred to a center.
A clinician at the treatment center will evaluate the baby for either a tongue-lip adhesion, jaw distraction, or a tracheostomy, and may plan for a gastrostomy for long-term feeding. The decision to do a gastrostomy is usually made within the first 2 weeks of life or at the time any other surgery is performed. Parents are taught how to feed their child through the gastrostomy. They should be alert to possible complications, like local skin infections, leaking of formula around the site. And of course, removing the tube and closing the opening may have to be done surgically. The alternative to a gastrostomy is a nasogastric tube. This can be successfully used for the first 3 months of life. The problems with nasogastric tubes are threefold. Medical personnel need to reinsert the tube if pulled out by the infant. There is a greater danger of aspiration, and long-term use of nasogastric tubes can cause oral aversion.
The gastrostomy is the preferred method of feeding because it guarantees that the infant will have access to enough calories.